Welcome, everyone, to the second session of the 2021 Hypertension Control Summit. This is an annual event and part of our continuous efforts in Texas to improve hypertension control. We're excited to continue with this virtual Hypertension Summit series and grateful, really, for everyone for being with us today. Thank you for those who are returning from the first session. The recording is still available for those who may have missed it, and grateful for those who are joining us for the first time. I'm Allison Smith. I'm the program director for Target BP, which is a joint initiative of the American Heart Association and the American Medical Association. And I'll serve as your MC and moderator today. I just have a few reminders before we begin. In this Zoom webinar, all participants will be muted. And you'll see the speaker video next to the slides, and you can adjust the relative size of those two by sliding the bar between. We're going to use both the Q&A function and the chat function today, so please use the Q&A function to ask specific questions to the speakers, and everyone can go and look to see what questions have been asked and upvote them if they're a question that you share, and those will bubble to the top of the list. We can also use chat for any comments or questions. You'll also see us drop some links to key resources in the chat along the way. So we really invite your engagement in there. And to begin, we'd actually love for everyone to introduce yourself in the chat, your name and your organization, just to give everybody a sense of who's around our virtual table today. All of our sessions are going to be recorded, and they'll be posted on the website registration page along with the slides. So rest assured you'll have access to this content and the great remarks of our panelists and presenters today. We have another packed agenda. So if you'll go to the next slide, we really will be focusing on social determinants of health and clinic to community connections today and the role that they play in managing hypertension. We'll hear from 3 community leaders to discuss their work and have a great panel discussion, I'm sure, following, and that will be informed by your comments and questions as well. So please remember to use the Q&A to ask questions and the chat for comments. So to provide a little context for today's discussion, we're going to begin with some remarks from Dr. Eduardo Sanchez. Before joining the AHA, Dr. Sanchez served as vice president and the CMO for Blue Cross Blue Shield of Texas, and also prior to that as the commissioner of health for Texas. He also currently provides medical leadership to Target BP as the American Heart Association's lead and as the principal investigator for the National Hypertension Control Initiative, which is a HRSA and Office of Minority Health funded effort of 350 health centers across the country. So with that, I will turn it to Dr. Sanchez.
Thank you so much for that nice introduction. Truth is, I'm not with you live, but I'm with you in spirit. I want to thank each and every one of you for what you do every single day to make a difference in people's lives. I get the privilege of serving as the clinical lead for Target BP, representing the American Heart Association. And today I get to tee things up for the conversation that is going to be had about social determinants of health, social needs as they relate to blood pressure control. I'm going to start by reflecting on 2020. 2020, the year of COVID-19. COVID-19 not only was the third leading cause of death in the United States of America, but it had a destructive wake behind it. And all causes of death increased. Yes, heart disease and stroke continued to be number 1 and number 5, but not only did more people die, but even the adjusted mortality rates were higher in 2020 than in 2019. In addition, when one looks at deaths due to hypertension, same thing. While it's not among the top 10, hypertension kills people, and those mortality rates increased from 2019 to 2020. One thing that we talked about the last time I was with you was the incremental but very positive increase in blood pressure control in Target BP in Texas. And that's what this is demonstrating. But there are some other things and other ways of looking at this that are at least cause for concern or reason to pause and just think about what it all means. One is that blood pressure control in community health centers overall dropped fairly substantially from 2019 to 2020 based on UDS data. There had been a fairly impressive increase over 4 years that then dropped down below 60% overall. In addition, we know that nationally, blood pressure control, when one looks at national numbers, not only folks in federally qualified health centers or health centers, not only folks in any kind of healthcare setting, but the population overall, Muntner et al. Did a study, and that's not captured here, that over the course of about 15 to 20 years, there was on the front end, the first half or so of that period of time, a fairly steady increase in blood pressure control in the United States overall. Then there was kind of in the early part of the second half of that phase, or a second phase, where there was kind of a flattening, a plateauing, if you will, of blood pressure control. And over the last couple of cycles of NHANES, and we look at NHANES data, that's the National Health and Nutrition Examination Survey. It is our health survey conducted over the course of 2 years. So our data is 2-year data. Over the course of 2 cycles, 4 years, in other words, numbers have actually dropped in the United States. But what I wanted to do was focus on some of the sub-analysis that can be done with the report that came from Paul Muntner. So I want to focus on a few things. One is that when we look at the bottom of this table, you'll see some race, ethnicity factors, characteristics. And what I want to highlight is that, at least according to this study, in this study, the blood pressure control rate among non-Hispanic Black persons, non-Hispanic Asian persons, and Hispanic persons was substantially lower than that of non-Hispanic whites. It's something we've got to pay attention to. Race, ethnicity is indeed a social determinant of health, according to many. And it turns out that when we look in federally qualified health centers, the numbers are a little bit different. Non-Hispanic Black control rates are the lowest, and higher are non-Hispanic white, non-Hispanic Asian, and Hispanic control rates are somewhere in between. But I want to focus on a handful of other social determinants of health factors. At the top of this table, first 3 rows are education attainment. And what you can see is that having less than a high school graduation or attainment is associated with a lower prevalence of control, dramatically lower compared to those who have high school and some college and those who have graduated from college. When we look at income levels, there is also a gradient. And what you can see is that for persons whose income is less than $20,000 a year annual household income, the control rates are much lower, and they increase as the income brackets move up, getting to 50% level of control in persons in households with $75,000 annual household income. When we look at insurance status, again, interesting findings. I don't think they're terribly surprising. Medicare has, at least people with Medicare have the highest control rate. People with private health insurance have the next highest control rate. Persons with Medicaid have a control rate that is lower than the previous 2 categories I mentioned, but persons who are uninsured have dramatically lower control rates than any other category that I've talked about yet, at about 25%, actually 24.1%, according to this study. When one looks at persons who have a usual place of care, they have a blood pressure control rate that goes to 50%. If they have no usual healthcare facility, that goes to 27%. That bodes well for persons who are getting care in a health center. It's going to increase the likelihood of blood pressure control. And here's one that I find really, really striking, really, really important to keep note of. And I'm going to end with the next slide, is that folks who've had no health care in the past year, 8% blood pressure control. And that speaks to the importance of keeping people engaged in clinical care once they've been diagnosed with hypertension. Next slide. Oh, I'm doing the slides. I'm so used to saying that. So here's the last slide that I want to share with you. This is a very, very recent report published in JAMA Health Forum, Cole et al. And it's a study that looked at the association of Medicaid expansion with 5-year changes in hypertension and diabetes outcomes in FQHCs. I want to note a couple of things. One, this took place, this analysis is a pre-COVID analysis. But what they did is that they compared those FQHCs in states that had expanded Medicaid early on with FQHCs in states that did not expand Medicaid at all in the 2012 to 2018 interval. And I just want to show you that there is a small but important improvement in blood pressure control across at least 3 groups: non-Hispanic white patients, non-Hispanic Black patients, and Hispanic patients, and very dramatic increase among American Indian, Alaska Native, non-Hispanic persons. And I bring that up because the American Heart Association is all about not only making sure that blood pressure control happens optimally, but also making sure that folks have the opportunity to have blood pressure control occur optimally. And we stand behind and advocate for Medicaid expansion in all states that have not yet done so. Texas is one of those. Health insurance status is a social determinant of health. Let's not forget that. And so with that, again, thank you so much for the time. Thank you for so much for the opportunity. I hope you'll have a productive rest of this summit seminar.
We are grateful to Dr. Sanchez for sharing that message with us and really helping to frame the discussion that's going to follow today. The social determinants that he enumerated will certainly be brought to life through the work in communities across Texas that our panelists will address. And some of the policy issues that he ended on will certainly be addressed at the end through our advocacy team. So we're really grateful for his support in that regard. Moving on, we're going to shift to the rest of our panel presentation. And if you could advance the slides. We are delighted to hear from community leaders across Texas who are working to combat social determinants of health to improve healthcare and hypertension control. And just as a reminder, I think some of you have found the Q&A function to really share your questions with us. One has been answered already with regard to the interviewing techniques associated with COVID and vaccination hesitancy. So that resource is in the chat as well as in the Q&A, but if you could channel your questions to the Q&A, that would be really helpful. So I want to move to introducing our first panelist, one individual who is well known to this audience, Heidi McPherson, who has almost 20 years of professional experience in public health and community development, serving at the local, national, and international levels. Prior to joining UT Health, where she is now, Heidi worked for the American Heart Association's Houston team, where she developed the statewide strategy that we're living in right now to improve hypertension control. And it really, she's been instrumental in playing really driving this, creating and expanding this annual summit. So we're grateful for her, the legacy of her leadership. She has also served as the co-lead for the Health Equity, which is the role that brought her to UT School of Public Health and the Michael and Susan Dell Center for Health Living, where her focus is on further developing the impact of this collective effort. So I will turn, Heidi, the virtual stage is yours. Thank you.
Thank you so much, Allison, for your kind words. And it really is exciting to be able to come back and share the work that I'm able to do currently and how this links back to the social determinants of hypertension and hypertension control. What a powerful slide from Dr. Sanchez of the disparities across the different social determinants. So really glad to be here with all of you. I see lots of familiar names in the chat. Let's go ahead and jump right in to the next slide, please. And I'll talk a little bit about what social determinants, starting at the very basics, really. There was a great issue of Texas Medicine this month and that focused on social determinants of health and really looking at those community-wide opportunities to move the levers to improve these health outcomes. You can see the kind of traditional breakdown of what are the factors that determine our individual health outcomes and how do we get to those, and how do we get to those on a scalable and systems approach that can be integrated and built the clinic to the community connection, as we talked about just a moment ago. Let's go to the next slide. And so recent findings here, I thought this was a great paper. It was back in 2019, so again, before the pandemic, but really looking at the opportunities to make changes in the social determinants of health and how that impacts directly hypertension and also cardiovascular disease. But that the opportunities are for innovation. So doing things the way we've always done them is not quite going to cut it. We've got to innovate. And what does that mean? Breaking down the silos, really coming up with those multidimensional interventions. And that means working across sectors. That means working above the level of organizations, linking organizations so that they wrap around a patient with the care that they need across all those sectors. How do we build those systems? And that's the work that I have the privilege of focusing on currently in my role at UT Health and co-leading the Health Equity Collective. Let's go to the next slide. So what does that mean? What does it mean to take a systems approach to social determinants of health? That's so big. How do we wrap our minds around that? Within the collective, we've had a work group of experts led by Michael Walsh of the prevention branch of MD Anderson and Nadia Siddiqui with the Texas Health Institute, but really 40 professionals and experts leaning into how do you align a system with the 140 organizations of the collectives that really charts a path to making a change together. So quick orientation here. On the bottom half in the very dark blue, you've got the drivers of health, which starts upstream, the societal values of valuing all people and communities equally. All the isms are wrapped up in that. And then how that plays out in your policies, both at the public and the institutional level, how those in turn inform living conditions. And you can see how much is wrapped up in those living conditions. A lot of that was reflected in that and the disparities of hypertension outcome that Dr. Sanchez just went over. And those in turn inform behaviors, which in turn inform the health outcomes that we're trying so hard to make improvements in. And so what can we do at the systems level together? At the top half of this graphic, we've got 4 buckets of action. Building the capacity for health and social services coordination. What does that mean? What are the data, the technologies, the human capacities that are needed there? And then what are the programs and the interventions that go across sectors, go across a clinical setting to the community setting, to the public health setting? How do we take all of that and advocate for policies that hold those changes in place and create the broader opportunities? And how do we learn? The systems approach is nascent and developing at best. We have to build our interventions based on the best evidence out there, but we also have to be evidence generating to contribute to this growing type of work. And so that's the journey we're on. Key here, you'll note at the top and in the center, we've got community engagement. You can't improve the community, meet the needs of community members without them being at the table. And within the Health Equity Collective, we're 140 organizations strong, organizations that care about health and health equity, lots of clinical friends, lots of community-based organizations, lots of public health and higher education and researchers. How do we create space for community members to come in and sit at that table and inform the development of systems change in a way that actually meets their needs, beyond just the needs of the organizational stakeholders? That's a big part of the work that's taking shape here in the Houston region, and really critical as we're building out the systems to address social determinants of health, that we're listening and building off of the patient's perspective. Let's go ahead and move to the next slide. So just a quick side note, you can see a little bit more about the collective. Happy to chat in another forum if anybody's interested. You can see our vision and mission of building that impactful, collective, sustainable, data-driven system to promote health equity. It's a lot. And really looking to be that driver for an ecosystem and improved approach to social determinants of health and health equity. And you can see the journey we've been on with over 425 members, more than quadrupling in size over the past couple of years, and anchored by the American Heart Association, Harris County Public Health, and UT Health. Let's go ahead and move on to the next slide. And so the work that's happening in Houston is, and this evolution of a systems approach is not happening just in Houston. It's happening all over the country. Everybody's trying to figure this out right now. And I wanted to raise that up because it's important as we build the systems locally in our communities that we're aware of what's happening at the broader level. And we do things that are in alignment with that. There's a lot of mechanisms for change here. And so you can see NASDO's approach, Civitas for Networks for Health, which is really looking at some of the health information exchanges and the capacities of aligning patient data. Over 95% of the patient data in the country is now represented within the members of the Civitas Network for Health. All in One is a broad effort bringing individuals across the country together to dialogue on a virtual platform and learn from each other. Congress is getting into this. They've just set up a social determinants of health caucus. Actually, they were calling for input. The deadline for input is today on what they should focus on for social determinants of health. And then looking at some of the data standards to allow healthcare sector data on patients to interact with community data. A key part of that link between clinics and community is that they can talk the same language and share data on the same individuals. One of the exciting pieces there that's coming together is actually through the Gravity Project, which is works in partnership with ONC to define social determinants of health concepts. So when we say food security, what does that mean? When we say intimate partner violence, what does that mean? When we say housing insecurity, what does that mean? And then those definitions, the ONC is taking them on to CMS for recommendations of having them be developed into ICD-10 codes for CMS billing. This is your future sustainability for this type of work. It's important to be aware of how these definitions and data terms are coming together. And Texas, well, we're not at the forefront. There is some exciting work there, and several studies that came out on Medicaid opportunities in Texas and Medicaid reimbursements on social determinants of health that I think really chart the course. There's a lot in those recommendations. There does seem to be some consensus and rallying around food insecurity, housing insecurity, and transportation. There's other things in there as well, but those keep bubbling up in a lot of these conversations. And then you could see there's a lot of conversations about how do we link what's happening around Texas to make it more impactful, and some of the stakeholders that are involved in that. So that's a lot of the big picture pieces. Now let's go and talk about what do we do at this level. Next slide, please. So when you're looking at the role as clinical providers, there's actually two levels to think about this. And the first is the individual level and the patients. How do we build those clinical workflows that create capacity for whole person care? And there's a lot of movement in this area from different directions. The first being applying evidence-based practices for screening and referring for social determinants of health. And again, this is an area where there's a lot of learning within the collective. We've done a lot of focus groups and a lot of studying of the different members of the collective and across the Texas Medical Center of who's doing what in screening and how is it working and what's not, and how do you create a safe space for patients to really acknowledge that they're struggling with something like food insecurity or housing insecurity, and then how do you address it? You can't just screen it and not do something about it. What are those linkages and what are the systems to be able to provide patients with those social services that they need if they screen that they do need them. And then the team-based care strategies of who on the clinical care team has the capacity to address this and do it in a culturally sensitive way. And what are the value-based care strategies that are incorporated into your clinical workflows, and how to create space for those, knowing that does seem promising, particularly in addressing and improving capacity to address whole person care. So that's on an individual level where some of the evidence points we need to spend more time and develop further. And then on the community level, looking and understanding what's happening across different neighborhoods. There's so many needs assessments that are done, but the data on the social factors is not necessarily always connected to the health factors. How do we build that in and understand what those opportunities are in a more powerful way, and then be able to track that? That requires tracking of data across systems and sectors that we talked about a moment ago. And part of the opportunity for being able to sustain that type of work is to understand the reimbursement opportunities that are happening at the national and state levels as they develop and weigh into those. That's where some of the policy change opportunities really lie. And the advocacy opportunities, right? I know Alec Puente is going to share more about that at the end of this session. And because all of this work is so new, a call to action for y'all is having your organization and your clinic be represented within the many health coalitions like the Health Equity Collective. Once you start asking questions, it turns out most, if not all, of our communities around the state have at least parts of these conversations happening in health coalitions. And if we all lean into this together, we have the opportunities to make the changes that we would like to see and have healthier communities and a healthier Texas. So with that, I will pause. I believe that was the end of my slides. Yes, thank you. And I will turn it back to you, Allison.
Heidi, thank you so much. Really great to have you back with us. Your presentation really created and provided a framework for us to have this conversation layered on top of the data that Dr. Sanchez had shared. And while social determinants are not a new issue, they've obviously been around all along. I think our awareness, our sensitivity to them has just exploded in a way that I think is very hopeful. And while we develop the capacity, the methods, the evidence, the relationships to change them, this time I think is exciting and a little messy while we figure out how the healthcare system starts to work more effectively with the social care system and the communities and individuals that they serve. So thank you so much for providing that really important framework. As well as a flavor of what's going on nationally and locally. So now we'll turn to our next panelist. It's my pleasure to introduce Judge Barbara Canales. Judge Canales was sworn in to Nueces County as the first female county judge in January 2019. For the 5 years prior, she served as the secretary and port commissioner for the Port of Corpus Christi of Nueces County. Judge Canales' list of positions within our community and distinguished honors is extensive, with more current positions, including the Director of Emergency Management for the county, the Vice Chair of Coastal Bend Bays and Estuaries Program, a founding board member of the United Corpus Christi Chamber of Commerce, an emeritus board member of the Corpus Christi Hispanic Chamber, and founding member and president of Ready or Not Foundation, just to name a few. She is a distinguished professional and an active member of the South Texas community. So Judge Canales, if you'll unmute yourself, the virtual floor is yours. Thank you.
Well, thank you for inviting me here to be a part of this distinguished panel. And I think that the segment that I wanted to really highlight is just dovetails perfectly with our first two speakers. In fact, they've set the table perfectly for a case study. And that is what I bring you here today, is a case study of a region that we call South Texas. But I hail from the urban center, Corpus Christi, the largest metropolitan center on the Gulf of Mexico. And we are a regional healthcare center. So what happens in Nueces happens to affect the healthcare of over 14 different counties around us. And what we encountered in emergency management, as most of you in the medical healthcare profession know, is at the beginning of 2020, the pandemic only exacerbated what we already knew. And that is that people of color in our community disproportionately were being affected in sickness. And as somebody once said, you know, where there is hope, there is health, and where there is no health, there is no hope. And so our folks embarked upon an opportunity in emergency management to team up collaboratively with our Nueces County Health District. And we were very fortunate to have the dollars given to us by the Coronavirus Relief Fund Act, subsequently known as CARES, and as well as FEMA public assistance, to embark in a quite transformational study along with the Texas Health Institute. You've already mentioned Nadia Siddiqui. She worked on our project along with Ankit Sanghavi. And the dashboard was developed by the analytic geniuses of Accenture. And what we set out to do was quite intentional. We said, if we could get a handle on the social determinants of health, we might know where to vaccinate better. We might know where to set up pop-up clinics in a way that could actually achieve success. We might know where testing might be better suited. We may even understand how to develop better mental health programs if we knew more about our community, much more than we had ever delved in before. And so I present to you on slide number 1, basically this introduction. And you have to understand what your demographics are in Nueces County, because again, we were disproportionately hit twice now in the pandemic. We were number 1 in the country with COVID-19 positives per capita. That is not a distinction any county judge wants to ever have, but to have it hit twice is indicative that we had something very, very wrong in our community. And again, you don't know the value of health until sickness comes. And this is what happened. Sickness came to my home and it took a huge toll. Take a look at the demographics that are on slide 1. And what I can tell you unequivocally is that COVID-19 has disproportionately impacted certain areas of our community, and those overlap very, very well with what we know as the social determinants of health, having also affected the community as well. Poverty, transportation, food insecurity, many of those educational opportunities, many of those highlighted metrics that were already mentioned. Now let's talk about that in terms of what this summit is all about. Even though this particular case study was focusing for the purpose of COVID-19, as I tell all of my brethren in the elected world, you cannot unsee what you have seen. So whether we are talking about hypertension, we used over 40 metrics to develop our scheme here, and some of the slides you're about to see. And whether you're talking about diabetes or renal disease, stroke, heart disease, hypertension, our dashboard allows you to go in and really focus on which areas of our community are healthier and which ones are not. When you look at obesity, I will let you know, it looks like it's prevalent all over our community, unfortunately. It doesn't discriminate between zip codes. Let's go to the next slide. Some of our key takeaways involved zip codes. It actually indicated that where a person lived in my county, by the way, we're 373,000. We're both coastal, industrial, and country, very rural. We have a very diverse geographic makeup, but where a person lived did shape their opportunity to have good health. And in fact, in a frightening way, indicated how long they would live. This was a key takeaway that was shocking to so many people in our business community. Furthermore, we could break it down by zip code and take a look inside neighborhoods where there was a high rate of chronic disease, or now we know comorbidities, or a vulnerable population. This allowed us to institute novel, innovative programs that we believe have application to the same mission that the American Heart Association has, or the American Diabetes Association, and so many other strong nonprofits. Even our PCPs in our community can benefit greatly by taking a look at what our data has shown, because data drives good decision making. And again, what we saw were that the frontline workers, the uninsured, those living with chronic disease, were going to fare very poorly when sickness came. Let's go to the next slide. This is a good opportunity to take a look, and I know that the slides often don't help old eyes like mine, but if you can get a feel for the higher incident rate, it was very easy to spot for me, having been born and raised in these in my community, really understanding very easily when Nadia would say, "Tell me about Molina, tell me about Hillcrest." These were names of barrios or communities that I knew so well, to be stricken with all of the difficulties that so often come with a lower socioeconomic population. But what it revealed is an unfairness in the way that COVID was striking, and quite frankly, the way diabetes, obesity was also affecting our community. And all of these have a direct nexus to the mission that we're talking about here today in the summit. Our Black population is quite small in comparison to our Hispanic population, but where they live overlapped. And so it was very discouraging to see that the Black child mortality rate and the premature mortality rate of our individuals in the Black community was just sky high. In fact, they reported the highest in the county. And again, some of those neighborhoods that I have such fine childhood memories. While I'm not a doctor, my grandmother and her 7 brothers and sisters were the doctors to the poor. I grew up in her office wanting to be a doctor. Somehow I lost my way and became a lawyer, but one never knows when the twists and turns of life will lead you back to health, as it has led me back now. I can tell you that our rural community is really suffering from all of the ailments that you've talked about, this patchwork of social determinants that create these health challenges. In one small community alone, they marked over 52 deaths in COVID-19, completely disproportionate to their population. Why, they asked, why is it hurting us so? Well, it didn't make a lot of sense to a lot of people until you started to overlay this data, understanding that our own culture was also contributing to our own demise. The fact that we as Hispanics absolutely love to live multi-generationally. This was a blessing for family, but a real obstacle for COVID-19 entering the home. And so we have battled so many of these issues over time. I mentioned that we live in an industrial community, and we've always been very proactive and focused on the health of our residents. But I don't know if there's another slide here. Is there one more slide? I want to make sure okay, good. So just to sum up, we have a case study that you don't have to guess if the social determinants are an impact and a game changer. You now can unequivocally look at Nueces County, look at our region, and understand why we rank so low in the Wood Johnson or the Johnson Wood Foundation of overall county health rankings. Now we must act, and we must do something about it. I just want to point out that what's powerful about this data is that it can lead to not only better decision-making, better focused treatments and programming, but it allows us to take the American Relief Plan Act dollars and target where it will make a difference. We seek to do that in our own community. We seek to influence the Texas legislature to also use this data as an opportunity to send focused dollars our way. We know exactly where they need to go. Thank you.
Judge Canales, thank you so much for being with us today and sharing
Absolutely.
this important perspective. It's very informative to think, we talked about national data, we talked about a national framework, and this is local data. We are obviously funneling in on where this work is so importantly happening in communities. And that leads us to our final panelist, which is Mercedes Cruz Ruiz, a state certified community outreach worker, instructor, who is just passionate about bringing health awareness to underserved and low-income communities at the grassroots level for really the past 25 years. For 15 of those years, she's been an advocate and volunteer for the American Heart Association, for which we are grateful, and has worked on multiple community health campaigns. As a community health outreach worker, she's taught over 1,700 awareness workshops and reached thousands of community attendees and trained hundreds of community health workers. And we're really delighted to have her here with us today to share a perspective from her experience and her expertise to put yet another layer on this conversation today. So with that, Mercedes, I will turn it over to you. If you could unmute yourself and use your video if you wish.
Good afternoon, guys. I am so grateful that I was invited to the table to talk. Actually, BP is dear to my heart. I am not only a community health worker that have been in the community for years, but I am a mini stroke survivor. I have high blood pressure. I have massive calcification in the arteries of my heart. I am a person with diabetes. So I learned a long time ago when I first came across American Heart in 2005 that I couldn't fight a disease I couldn't understand. So my journey began to try to shape our communities and to change. So with that said, been part of American Heart, teaching just the community in general, but then decided that I needed to empower more people. Mercedes couldn't do it all. Although, I am the co-founder of Vestido Rojo, that got started in 2005, and we've done great works with those programs, but I really wanted to go a little deeper and really, really train community health workers. Now, some of you may know what community health workers and some may not. I am a community health worker instructor, so not only do I serve as the community health worker, but I also get to do full trainings to train them and provide CEUs. So our community health worker, we are the grassroots. We are that trusted member that deeply understands, and I want to put the word deeply understands the community he or she lives in and serves in. Okay. So they are trained public health workers who serve as that bridge. That's what my company is called, Health Bridge for You, between community, the healthcare system, and state health departments. Remember, CHWs are going to be your liaisons between health and social services in the community. With that said, I want to tell you, in 2019, I came to American Heart and I said, how about if we start a program that we can train community health workers on heart, stroke, high blood pressure, and everything else, just like I have been trained and I have been doing for the past 13 years at that time. And sure enough, we sat, American Heart came up with some funding, and then the work began. So we came up with the idea that we were going to train community health workers on 30 hours of heart and stroke, and then have them do a return on investment by the number of people that they were going to touch in the community. Right now, who is going to be these community health workers that we were able to train? Well, they were from local companies and local clinics. Like we train people from John Peter Smith, from Baylor Scott and White. I had two people from Grace Clinic in Grapevine, Superior Health, Cook Children Health Plan, Aetna Better Health, UT Southwestern, AgriLife Extension, the Federally Qualified Health Center in Northside, AmeriGroup, Tarrant County Health, the Bureau of Prisons and Adult Protective Services also were there, a president of a regional LULAC, Maximus, the state contractor, and UNT Health Science. So we touch not only the individual CHW, but also we kind of, touch all these agencies, because those CHWs not brought though that message of heart disease and stroke, especially high blood pressure. Sorry, my strokes kind of make me talk when I get nervous, talk a little rowdy, but they brought that message into that company. So we were excited about that. So what were we able to do? Well, one of the things we were able to do is that we were able, from 2009, and that was September 2009, to now August of 2021, we trained 621 CHWs on how to properly take blood pressure measurement. And we know blood pressure measurement is key to getting the right numbers and getting the people diagnosed correctly. Okay. Out of those 624, and those were done either in person or virtually, 92 of them received blood pressure cuffs themselves. We equipped them with blood pressure cuffs, the ones that went through the 30 hours, and each of them were required to touch 50 people. So imagine 50 people times 92 were directly required under the training requirements, that they had to tell me the name of 50 people that they share the information with, that I would know directly that they did that. So they reported that, and that was part of the grant requirements. But on top of that, when COVID hit, there was a zip code that I lived in. And remember, I'm a CHW. I have lived in a lot of zip codes in the DFW area because I always immersed myself into the community that I was serving. Now I bought a house and now I'm only in one part, but before 76106, where Vestido Rojo got started, it's been dear to me in my heart. And when I found out that they were hit with COVID so badly, I needed to mobilize the CHWs and say, we need to do something for them. Okay, so we went out there and we produced 14 events, educational events, but also food distribution. We did Depends diapers because they were a need for that also. We did COVID testing sign up for people. We did pop-up shot COVID shot clinics also. We went ahead and did a lot of PPE distribution. We distribute over 5,000 masks to the community and over 6 pallets of hand sanitizers through them. So out of those 14 educational events, 1,346 blood pressure educational material provided, and 1,473 community members were educated. So I always say that CHW is definitely the ones that are going to, that are going to be out there at the grassroots level, really trying to touch the community to make sure that that the need is met. And there's no better person that understand the community than those that live in the community. I don't ever go in and provide any project without first consulting with the CHW that I had in the many zip codes that CHWs are, but also diversity. We just don't have, although I'm Hispanic, CHW has not just Hispanic. I have CHWs in every culture and religion background, because as we know, also cultural diversity plays a role. And with that said, CHWs, we're the movers and the shakers in the community. And I thank you for the opportunity you've given me to talk about CHWs and what we can do. If you want more information, I'll be more than happy to share. But with that said, it's a pleasure to have served you. Back to you, Allison.
Mercedes, thank you so much for sharing your personal story with heart disease and with sharing your expertise and the amazing work that you've done throughout your career, as well as how responsive you've been during the pandemic and the lives that you've touched in that way. So, wow, our panel has really provided a few major dimensions to help shape this discussion as we move into the panel portion of our program. It's my pleasure to introduce our panel moderator, Dr. Amran Rauf, and he will lead us in a discussion with our panelists about social determinants and how they can have an impact on hypertension control. Dr. Rauf is the Chief Medical Officer at Cigna Medicaid, where he leads quality care, utilization management, and value-based care initiatives. As a practicing internist, he specializes in managing chronic conditions in adults, such as hypertension, diabetes, and cardiovascular disease. And he's passionate about leading quality improvement efforts on hypertension and other cardiovascular diseases. So we're grateful to have him also as the new chair of the Texas Cardiovascular Disease and Stroke Partnership. With that, Dr. Rauf, I invite you to the virtual stage along with your panelists, and the floor is yours. Thank you.
Hello, good afternoon, everyone. So this is a really exciting time because now we are learning a lot about, definitely about social determinants of health with regard to chronic disease management, improving health outcomes. And our focus on today's session is really about having those discussions, finding the connections of those important variables pertinent to cardiovascular disease control and definitely hypertension control. And this aligns with our broader objective of setting a goal of making hypertension control a national priority, as put forward by Surgeon General's call to action. So both AHA/AMA, HHHC, and I believe most health systems and insurers may have made it a priority to control hypertension. As many of you know, health systems, accountable care organizations, and insurance, hypertension control in populations remains a topmost priority. And with that, we definitely need to focus on disparities. We heard a lot about disparities and social determinants of health that are related to hypertension control. So hopefully we'll spend the remainder of the time to learn from our panelists about some of the connections of some of those important variables, and also about understanding and finding out, particularly from the community level, the variables or the factors that we should act on. Next slide, please. This is a busy slide, but I really want you to focus on maybe some of the inner circles. If you look at the individual patient level and the provider level, those are your micro level factors that can contribute to disparities. And then if you go out to the periphery and look at the other circles, those are more macro level, like national health policy environment, state health policy environment. We probably need to work on both fronts, both on a macro level and a micro level, but knowing that at least in the audience, we have mostly health system leaders and providers, we should really focus on what we can influence. We can definitely influence our work environment, our communities, our patients, and our providers that we work with. So I hope that we'll learn from our panelists about how do we do that in terms of understanding problems in the community level interventions pertinent to hypertension control. Next slide, please. Yes, yeah, if I could have my camera on, that would be nice. I was trying to do that myself, but I think on my end it's not working. So while we're trying to figure out how to turn my camera on, I'll just, let's see. Okay, so I hope I'm visible. I'm not sure myself. Anyway, so I'll keep going. So with that intro, my first question is for the panelists, is really about community level assessments. And I really want you to focus on cardiovascular disease and community level assessment. So what's your impression about assessing community in terms of needs and variables that we should focus on if we need to work on cardiovascular disease control and hypertension control? In a sense, how do we go about doing some assessments of the community in terms of resources or factors or variables that we should focus on? So that is my question to the panelists.
Well, I'll start and just tell you my experiences and what I think works. I can tell you what doesn't work, and that's to tell them what they need to do. And I can also tell you that telling them that they're dumb for not doing it is the worst thing. We have learned so much from this pandemic that will serve us so well if we have the courage to just listen. So what I would suggest is that what works in my community that's so diverse is to go to them. In other words, meet them where they live. Do not presume that you're going to come to a hospital and have wonderful dialogue, or even the university can be daunting. You're going to want to find community centers, trusted places. Could be the basement of churches or the parking lot. Some of my best clinics are in parking lots outside churches. You also need to make certain that you can meet them where they are with the people that are like they are. In other words, don't send somebody who doesn't look like them, talk like them, or walk like them. Give them, and by the way, we're everywhere. This idea that we cannot be like our constituents is a myth. It doesn't matter what people will tell you. There is somebody in your organization that you need to bring up and lift up, and they will be your new messenger. Make sure that there is language-based appropriateness. For example, I live in a community, I don't even notice it. I speak Spanish as much as I speak English. I come in, I come out. It's very normal. They like that. Some places have a Korean, background in the particular neighborhood I'm thinking of, and a Spanish background. Now that one is an interesting one, but there is somebody that works in a convenience store that understands both. I guess what I'm saying is that this concept of meeting people where they are and where they live is very powerful. Finally, I would suggest public messaging must be utilized to the highest degree. I cannot express to you how I spend so much of my day correcting misinformation. How are we supposed to get the right information if they're being bombarded with the wrong information? Well, the way you do it is you must be louder than they are, whoever they are. You must use the radio waves. You must use television. You must use digital media. You must use, I go to the mall. One of my best clinics is in the mall. You know why? Because that's where the people are. And that's where I can talk to them. And when I give a vaccine, we are also there to take their blood pressure and to talk to them about their nutrition and make sure they check those A1C levels. That is my best advice. I've seen it work. The campaigns must be authentic. They must be real, and you must use real people. A lot of this stuff is scary. And we have to be mindful of that. Everybody on this call is an expert. You're not scared of the biggest words or the most complex of data because you live in it, but they don't. And so I just would say that keep it simple, keep it real, be authentic, and don't ever send anybody in there that doesn't absolutely love what they do. If I catch any member of public health complaining, they're out immediately. Only passionate people live where we need to preach. That's what I wanted to say.
Thank you, Judge Canales, for your passion and for your leadership on this. So much needed. Right, I'm going to turn it over to maybe Heidi. I'm going to put you on the hot spot, if I may.
You know, I like to talk. Judge Canales is exactly right. When we talk about data, an important set of data is that it's informed by the community. That needs to be thought of as the critical data gathering activity. We focus so much on these broad national data sets, or we need to develop this capacity of surveillance. An important piece is just going and talking to the communities about what it is that they need. And there's so many examples of this. You know, I lived for 10 years in a very Hispanic part of Houston. And lots of disease rates, diabetes, hypertension, et cetera, in that neighborhood. One of the key barriers for outdoor physical activity was all the loose dogs. Everybody let their dogs out to get exercise. So it didn't feel safe for the people to go out there too. And you're not going to find that out by some national data set. You're only going to find that out if you go and talk to the community members. And then build solutions with them. They're the ones who know what's going to work in their community and meet those needs. It needs to be that conversation. And how do you create that link to the clinical providers that are here with us today? There's so many opportunities in Mercedes. I think that the community health workers and strengthening that network is so key for developing the capacities for communities and clinics to understand each other's languages. That seems like a really, really key thing. And with the ARPA funding, with the CARES Act, et cetera, we've got some unique opportunities to make the investments for that type of infrastructure and capacity in our communities across Texas. I'll stop there.
Thank you very much. All right, any other comments or thoughts from the remaining panelists?
Yeah, And totally, Judge Canales in Heidi. Sorry, my pronunciation might be a little off. So my apologies for just calling you by your first name. But one of the things that that's very so true is going into the communities, but already, like I said before, find the person in the community that they all trust. Because I don't go knocking at any community until I find and I do my research, who's my CHW that I have there? What does she do? How can she connect me? And I fit into every community. I even have CHWs in the Muslim community, and I'm able to go in there because I'm passion driven, you know so it engages people, but that's the way I go. So one of the things that were able to be successful for me is that when I found out that 81% of my community health worker suffer either themselves or family member of heart disease, I had their buy-in into the message that I was trying to deliver so they can impact other people, right? So they already had a buy-in because they were touched by it, right? Then we said, okay, but we need to learn how the rest of the community fits during this COVID, what they're thinking, what are they, what's going on? So we did 944 surveys, and this was not done by just one person or an agency. It was that CHW, that her contacting her friends, her peers, and surveying them. They weren't going to answer to me. They were not going to share intimate details about what's going on in their life through COVID, what was their need going to be, but they shared with her. And then they all translated it, okay, to us. We broke it down and we found out that there was fear, mistrust, there was mental health issues. So I know I'm a certified mental health instructor. I needed to step up my game on that. And then there were some lack of resources. And we went to the table and we said, okay, who has what? You got tomatoes, I got apples. Let's bring it to the table. And then we were able, and we really wasn't about apples and tomatoes, but you know what I'm saying. You have this, where can we go find? And that's how we were able to assess at a lower level, not high up, not very, unique. We were paper and pencil, okay? Like taking paper and pencil and doing the survey. So that's my take on doing. Sometimes it'll take hierarchy, middle archy, and then the grassroots level where they're really going to trust you, and once they trust that person, they trust you as the person that can come in and help.
Thank you. So I'm going to turn over to our audience chat box and see if I can find a question or two for our panelists. So this comes from Roy Champion, and the Roy's question is about the high school programs that could play a role in terms of the awareness and control of cardiovascular diseases, suppose. Anybody has any thoughts about, what, we could do in terms of starting early from high school or other learning environments, maybe college, in terms of raising awareness of cardiovascular disease? Any comments or thoughts?
Yeah, so basically one of the programs that I have done throughout the years work with school districts, ISDs, and we go in and provide education via label reading, how nutrition fit into heart disease and chronic diseases. So yeah, some of those 1,700 classes and workshop I have done has been to 4-year-olds, because I do heart power with the little ones and they check their heart with the scopes and stuff, to my latest CHW that graduated, she was 80 years old. So technically, yeah, we strive to work with the community and we don't exclude anyone from the community. And schools are a perfect way, because I have always told school districts that you can graduate them as whatever you want, but if they're not alive to fulfill their career, what difference does it make? So if we don't keep our children safe, that are our future, what future are we going to have? So yeah, I think education, but health needs to be toe to toe. And in my
Thank you.
Yeah.
Thank you, Mercedes, for your input. Appreciate it. I want to shift gears and maybe focus on the community level connection. We talked about having a trusted community-based resource. We also know that there is an increased attention to community level interventions. Dr. Judge Canales mentioned about community-based resources and campaigning, advertising. We also know, as of 2018, a landmark study showed that barbershops, black barbershops where hypertension control was managed by pharmacists, there was a significant improvement of hypertension in African American patients. So to that point, my question to the panelists is, how do you get your clinic level systems to communities when you know for sure, hey, this is a resource. If a faith-based group that is dedicated to control of cardiovascular disease, or a barbershop, or other community-based resources that are doing good work, but we need to have the connection between our clinic and the community-based resource. How do you go about doing that?
So we've been talking about this very issue and whether or not it might be a smart idea to have sort of an incubator center, if you will, a holistic place where nonprofits could come and make certain that they're not duplicating efforts or initiatives, and also making certain that there is a connection between the work they do and whether they are, federally qualified health centers or clinics and or PCPs. What we're seeing is that our PCPs aren't getting the info. Let me just give you a great example. The rapid infusion centers, nightmare. It took us weeks and weeks to get that right information to PCPs. We think we need to have a center, if you will, that would help bring the silos under one umbrella, because I think that there's so many people doing good work, and right now the money's flowing like water everywhere. So there's going to be more people doing even more good work, but who is really watching? Who's really helping us bake this great cake? And I think that it would be very worth this great investment. And I just want to add one other thing to what you said, what would work. The other thing we're investigating, and this is just, you have 254 counties, you got 254 counties. What's right for us may not be right for Harris or Bear or Tarrant. But I want to suggest that a real emphasis and a return to green infrastructure could be a real game changer. If you look at the SDOH situation, what you see is that people don't have places to go and run and play that are safe. And we need to, big metropolitan communities get these all the time, but mid types of counties, which is the majority of us, don't. We don't have the amenities that a green infrastructure can supply that would promote the farmers markets, that would promote the festivals and the health fairs. And so I just want to suggest that by working with our PCP and our medical society environments and bringing them into the fold, they stay too far away. I am in a doctor's office right now, and I promise you, I'd like to leave this door and go teach a few things to a few people here. And I love them, and they're saving my daughter's life right now. But the point is that they are so disconnected. How can we bring them back in? We need a place where they too can understand their community. They are way, way too aloof, and we've got to bring them in the fold. I hope that provides some insight for you.
It does, and thank you, Judge Canales, for your insightful comments and thoughts. Clearly, having that community level connection, and really you touched on something that's near and dear to my heart, which is about some holistic fundamental structural changes where providers, community-based resources, some architectural changes are conducive to bringing about changes and conducive to improving health. I think Dallas-Fort Worth area may have a a system where there are community-based garden vegetables and providers are working in the same community. Patients are coming, they're doing exercises and whatnot. They're learning about fresh fruits and vegetables. That's wonderful. But I guess I'd like other panelists to chime in terms of what can we do to drive our community, our providers, and to community-based resources. Like could you think about scaling? So, for example, the article that I just quoted, published in 2018, the barbershops I think that study was done in LA County. How can we scale intervention like this, where great work has been done, our providers are in the community, in the barbershop, in faith-based organizations, improving cardiovascular care, other care? How can we scale this? How can we drive changes so that health system and providers are getting part of it? Heidi?
Yeah, I'll try to respond in a sentence or two because I think we're running up against the clock here. Dr. Roof, I think it comes back to a number of the things that we've talked about here. There's so many promising models like the barbershop, of building food pharmacies in a clinical setting, of building clinics in school settings. We've got to learn how to meet the individuals where they are in the community with health and healthcare. And that's innovating, that's getting outside of the current model, and figuring out how do we do that in a way that we can fund and sustain. It's a different type of care that will get us the outcomes that we want.
And with that note, I've been asked to wrap up. I want to be sensitive to the time. So we have learned a lot today, clearly starting from Dr. Sanchez to the comments and the presentations from our panelists. And thank you for the audience for your participation as well. I'm gonna turn it over to Allison.
Thank you all so much, Ms. Ruiz, Ms. McPherson, Judge Canales, Dr. Roof. Really appreciate the dialogue about how and what kinds of things are going to be really impactful to our communities, the programs. And I think we pivot now to one last segment of our program, which is about policy. And while programs are extraordinarily important in addressing the immediate suffering that we see in front of us, we think about policy levers, other systematic ways to create structural change in the environment and to address health equity and health disparities. So it's my pleasure to introduce Alec Puente. Alec is a member of the government relations team for the American Heart Association, and really delighted to have you here to share some specific policy perspectives on Texas. So thank you, Alec.
Yeah, thank you, Allison, and thank you everyone for being here this afternoon and the panel for that very insightful discussion beforehand. My name is Alec Puente. I'm the Government Relations Director for the American Heart Association here in Texas. And so I'm responsible for our public policy agenda at both the state and local levels. And so I'm going to give you a quick snapshot of kind of where we are at this point in time on our advocacy efforts, and especially what we're doing on hypertension. We can go to the next slide. So this is just a quick overview of our state and local policy agenda. I'll be happy to share this with anybody who might like to see the actual document that's screenshot there or get more details. But really, this just identifies at a high level what we've identified as being our public policy priorities for the next year at both the state level and at the local city and county level here. So some of those are shorter term appropriations opportunities, especially related to the federal pandemic relief funds. And some of those are, longer term, like health coverage access and Medicaid expansion here in Texas. Some of the other highlights in there are hypertension, of course, health equity, health coverage, and also nutrition access. And then importantly, it does not mean we can't be involved in other issues. We know that just kind of by the nature of this work, programs change, proposals change, policies kind of pop up. And so, we definitely want to hear what's going on and be adaptable to where policy is heading. And so we can head to the next slide. So just a little bit of background on what we've been doing over the past year. This month, a few of the bills we supported in the last session were made effective on September 1st. One of those was House Bill 786, which will require all telecommunicators to be trained in over-the-phone coaching and CPR to emergency callers, so they can have access to that service even if they're far from somebody who's trained in ordinary CPR. We've also supported Senate Bill 224, which will make it much easier for seniors and disabled persons in Texas to access their SNAP benefits and access for them for longer periods of time before they have to recertify their eligibility. There's Senate Bill 248, which will require e-cigarette retailers to secure a permit similar to that one required for paper cigarettes. And finally, House Bill 133, which will extend to 6 months the amount of Medicaid coverage that that recipients get after a pregnancy. There were also some unsuccessful efforts, which included implementing an e-cigarette tax and restoring some of the funds that were cut to the Department of State Health Services, including tobacco cessation and enforcement and some heart and stroke data collection activities. And one thing I should have also mentioned in there that we'd supported that did not get passed were a few bills that would have put some funding and structure towards a social determinants of health approach at the Health and Human Services Commission. There were a few bills passed on that topic, but they did not really gain the traction they needed to pass. However, I do expect that there will be similar bills filed next session that hopefully we can support and help get through to the finish line. After the regular session, as many of you know, I'm sure there were two special sessions called. Very little happened there because the House of Representatives did not have a quorum, and constitutionally they can't pass any legislation without that. But since then they have secured a quorum, enough legislators have returned to the Capitol, and there's a third special session ongoing that began yesterday. I was looking at the calendar. I will have more details on that in a later slide. We go to the next slide. Locally, we're also focusing on things like appropriations, health equity, and healthy eating. I think generally we're looking for opportunities that target disparities in heart disease, stroke, and related risk factors, hypertension also. Just some examples of those around the state. In Austin, we're hoping to pass an ordinance that will require all children's meals to come with a healthy beverage that's water, unflavored milk, or 100% fruit juice, instead of a high-calorie sugary drink or soda. We also supported a resolution and later budget appropriations to begin a process to implement a food system plan in Austin, Travis County that'll really kind of put the resources and policy framework in place to examine more city policies from an equity lens, especially those obviously that affect the food system. And it'll also kind of provide the structure to bring more voices, more stakeholders in to point to what would be some good opportunities for policy that consider the food system from a health equity lens. And then finally, in Harris County, I'm sure a lot of you are aware there are a lot of discussions about health equity. And so we are, again, just supporting initiatives to better deliver some of those services, some of those related support systems around social determinants of health to the population there, especially as it might be related to funding needs. And then we can go to the next slide. I'll go through this one quickly. And so this special session is happening right now. Among the items on the agenda is splitting up about $16 billion in federal relief funds. We imagine there will be a lot of different opportunities to make sure that goes towards some of those priorities you see listed there. One proposal we've started bringing to the legislators would involve increased funding for hypertension control programs at the Department of State Health Services, especially for outreach to kind of those high priority public health regions and helping to connect patients with the equipment they need for self-monitored blood pressure. And so that'll go on for 30 days, and we're hoping we can get some good outcomes from that special session. I think we have one last slide. And then quickly, what you can do if you're interested in any of this is you can text CURE to 46839. We are pretty careful not to bother you with too many texts, but we do have updates, especially when they're timely during the session, about ways you can get involved. Of course, you should tell your lawmakers what's important to you. A lot of times when something does not get through, what they will say is that they didn't hear from anybody. So we want to make sure that that's not the case and that they know what their constituents and what stakeholders are interested in. And again, if you have any questions or you'd like to share what your own organization's working on or other information you think we might be interested in, I'd be happy to hear from you. My email address is alec.puente@heart.org.
Mr. Puente, thank you so much for that update. It really has brought our conversation full circle. It's been a great day of learning from really national level data, local leadership and insights, and bringing this conversation about social determinants of health into focus in Texas. So thank you all. We're going to shift gears to wrap up today. Another amazing session packed with insights and expertise from leaders across Texas. We have a call to action, and we really encourage you to explore some of these resources around social determinants of health in your community. We specifically encourage you to join a coalition in your community to learn, to listen, to help create those clinic to community linkages and back to the clinic to community to clinic. There are just so many opportunities to address the factors that are driving health beyond the ways in which we deliver care traditionally in the healthcare setting. So we really encourage you to do so. On the next slide, I just want to offer a few closing reminders. I really ask you to respond to the survey of this event. The chat will appear in the link as well in a moment. That feedback is extraordinarily helpful to us in planning subsequent sessions this year, but also in incorporating it into the feedback for next year's planning. There's a link here, obviously, to more social determinants of health information, the website for the Heart Disease and Stroke Program, and also some more information if you want to contact Cassandra Hunt directly for information about joining some of your local collaboratives. So that's several great resources right here. And again, the slides and recording will be available to you. Moving on, I just want to the next slide. I just want to thank remind you to register for the next event coming up in October and one more in November. You can go to the registration page to register for all of them. So we really hope you will come back to reflect more on the impact of hypertension control through the pandemic in our October session and celebrate successes with our award celebration in the November session. So please be sure to join us there. And then lastly, on the last slide, I do want to thank all of the, we've gotten a hiccup here. There's more information about the Hypertension Control Learning Collaborative. There's some grant opportunities here that we want to call your attention to. A lot of details here that we'll just pause on for a moment, outlining the purpose, the components of the program, and some details about the application process, which will be opening again soon for primary care clinics. There's some awards available here, so check out that link on the texas.gov site. And then moving on to our last slide, I do want to thank the planning committee, not just the panelists, facilitators who you saw on the screen today, but all of those behind the curtain, if you will, who helped shape this event, bringing together the expertise and resources for today's program. With that, I just want to thank you again. Be well, and we look forward to seeing you again next month.